little bit of sunny afternoon here today, and we are here at some historic moment of time where the United Nations high-level meeting on antimicrobial resistance is being held. And the last one was held in 2016, and once again the world leaders are here to deliberate upon efforts and chart a new path to deal with this global health threat. AMR is one of the 10 top global health threats, and very often this, what we call antimicrobial resistance, is something invisible to the common person. And I love the slogan, AMR is invisible, but I am not. That is, the people who face AMR and go through it, they are the ones we should be talking to, and I'm really happy to have with me Nour Shamas, who would, none of us would know better than what she does know, what devastation AMR causes to the people. Welcome, Nour, and could you share your story of how AMR has impacted you and your family?
Thank you so much for having me and for talking to AMR survivors. I'm really grateful to see how everybody wants to hear what we have to say. And part of it is, from my perspective, I'm a carer for an AMR survivor who's my mother. I'm from Lebanon, and the situation in Lebanon in general is really tough economically. But in addition to that, the healthcare infrastructure is compromised, basically. So in 2018, we already started having an economic crisis, and at the time I was in the US at an infectious disease conference. I was called for that, saying that my mom has an emergency back surgery, spine surgery. And of course it was really scary, and we had to spend a lot of money on that because it's all out-of-pocket healthcare. A couple of months later, she started complaining of back pain, which for the longest time was expected to be back-related. But then, because she's older, her back pain actually turned out to be a urinary tract infection that had gotten into her kidneys, and then the bacteria got into her blood, so she had bacteremia. She was septic, so she was really ill. She was admitted to the hospital. Now, this could be any other story because all of us are at risk of going through this. But in addition to the risks and concerns about AMR, my experience is that the healthcare system failure that we were experiencing impacted our ability to take care of my mother. So we didn't have access to the antibiotics that, even though we could afford it, which already is a barrier, they weren't available. So we had to bring the antibiotics in from abroad. She had to receive antibiotics at home because of the hospital capacity and all of issues similar to that. In addition to that, like thinking about an elderly woman that had a hospital-acquired infection, you already had a problem with the, to have surgery. So the idea of having a superimposed bacterial hospital-acquired infection that is all for some reason so acceptable. I don't know why we accept hospital-acquired infections, And my mother, you and I are women, we understand what urinary tract infections are, but a lot of people don't. And one of the problems is that the antibiotics that we're using for UTIs are pretty bad. So my mom has recurrent UTI. Until now, she has recurrent UTI. She's very frustrated. She used to, at the beginning, thought it was a sexually transmitted disease. So she was worried about the stigma, about seeing an infectious disease consultant, what that would mean on in terms of how people will react to her and if people will be afraid of her if she's infectious. But even if she was infectious, of course, stigma is always bad. But it was very new for me as a healthcare worker that works in infectious diseases to perceive UTI as a source of stigma. It was very interesting, unfortunately interesting. And then the other part now that I was just in Turkey with my family last week because in Lebanon we have basically a war against our country. We have 500,000 internally displaced people. These are Lebanese and Syrian and Palestinian refugees that were already there. So triple displaced sometimes, people that have gone from house to house to house. And you think about the living conditions now that people are going through in schools that are housing maybe in each room 2, 3, 4, 5 families. So my hopes for this meeting were very high, but now looking at Lebanon and what's happening, I'm really concerned about, of course, the impact of war and conflict, but also the long-term impact on Lebanon, on the region, and how I think it's so important to try and think about things from multiple perspectives and not just think about AMR in a very siloed manner, but also think about what services, what policies can we do, can we work on to ensure peace and prosperity in health systems, structures that can promote, healthcare workers to stay in countries, and also improve hygiene and access to water and sanitation. So I mean, I know we've all spoken about a lot of these things. Really, sad but happy to share my story, and my mom is also very happy that we're able to talk about it.
Yes, thank you, Noor. Thank you for sharing the story, and thank you for pointing out that yes, we talk of the One Health approach, which is very important, but we have to see the other conditions and what impact war and hostility has on not just our well-being but also on in our efforts to control AMR, because this is a direct consequence of how AMR has impacted you. War has added to those problems. And that is what we have to deal with, because without, unless there is you can say peace and stability in the society, how can we even talk of having preventive measures? And as you said that despite giving the best of medical help, was a drug sensitivity test never done on her?
Yeah, very good question. Actually, we're very lucky as well because we are able to afford the diagnostics. So it was done. Of course, you can criticize how quick the results came back, because it did take a while to get her, for people to even think about UTI, for them to test her and then to give her the antibiotic. And then the antibiotic was, because she had a resistant infection, it wasn't efficient initially and she was still sick. And then, they increased the spectrum and used it. But you're right, because in many other situations in Lebanon, people wouldn't be able to get a culture.
Yes.
But, I'm also very aware of our privilege. And, this is it's unequitable, basically, access to diagnostics.
Yes, unequitable and also timely and unequitable access. So right now, are the antibiotics working on her? Because you said that she keeps on getting the UTI over and over again. So are they working on her, or are they still trying out new antibiotics?
Yeah, so far, yes, they still work, and we alternate between the two different options that we have. I'm always just terrified of the moment that we're going to look at the culture and we're going to have a completely resistant organism. I have to tell her that that's a possibility at some point, because we need to prepare people, and she needs to be empowered to understand what her infection is about. But yeah, so far they're working, but it's very scary, and I really hope there can be a bit more research focused on urinary tract infections in women. Things, antibiotics that actually work in preventing, long-term colonization, and looking at reasons for recurrence, especially in elderly, all women, but also especially in elderly women.
And you talked of hospital-acquired infection, which is a big issue. So, and you yourself, you said you are a healthcare person, so we would like to know a little more about what you are doing right now, and what needs to be done more to at least curb down these hospital-acquired infections.
Yeah. I really think that we really need to go back to basics when it comes to training healthcare workers early about infections and hospital-acquired infections. We all go into healthcare for many reasons, but most of us go in to help. And helping means doing no harm first. And I'm an infectious disease clinical pharmacist in background, and I run antimicrobial stewardship programs even before this happened to my mother. And every time as a clinical pharmacist, you see patients. Every time I walk into a room, I make sure not to touch anything in the room. Of course, you do have hygiene pre and post, but what I mean is I try to reduce the risk and the contact, and I only touch the patient if I have to, or if I feel like they're lonely and they need a pat on the back, and then I'm always careful not to harm the patient. And so I think that embedding this very important piece of information in risk and harm reduction into medical education for pharmacists, nurses, physicians, and not to leave it till after they've graduated to say, oh, by the way, infection control is important. So embedding this into education, and also, airplanes don't crash as much as we get hospital-acquired infections because of all the things put in place to prevent it. So I think we need to put a lot more work into making sure there are enough nurses at bedside, making sure they're not overworked, they're well paid, I love nurses, and I think they are the power horse of our healthcare system. So I think from that perspective, I really hope to see some change instead of just creating new guidelines and policies that don't work. We need to empower people to make the right decisions.
So you're working in Lebanon only, or
yeah, so actually, unfortunately, I wish I could work in Lebanon, but I don't. And I was also very blessed because I was working in Saudi Arabia for 8 or 9 years. I worked in the Antimicrobial Stewardship Program leadership and co-leadership. And now I'm consulting with the WHO on antimicrobial stewardship policy. So I'm very blessed because I've had experience in Lebanon, in Saudi, in the US, and I also worked in Cambodia at one point. And I really like problem solving. So finding very simple, cheap ways to solve problems that we all see.
Yes.
And at the end of the day, most of the time, it all goes back to behavior and understanding, and not education in a typical sense, but behavior and really understanding why we're doing certain things. And that's what I've been very blessed to be able to learn and hope to share as well.
all right. So from your problem-solving point of view or perspective, what are the simple methods you would suggest to at least control or to respond to antimicrobial resistance?
Thank you. So from my opinion, and I think some of it is evidence-based as well, first, like I mentioned, education, early education on AMR and infection control, and the just in general patient safety principles, because at the end of the day, AMR and stewardship are patient safety programs. They're not vertical programs. They shouldn't be. They should be embedded into patient safety programs, which is the responsibility of all healthcare workers. Of course, patient education as well. So improving, not focused AMR training, but social education, for example, making sure everybody has access to study, and that makes sure that everybody knows how to think, how to make informed decisions, thinking from a very wholesome perspective. But if you wanted to think a bit more detail, I think one really important thing is mentorship for the amazing pharmacists that we have worldwide, but also physicians and nurses that can take a really strong leadership role in stewardship. So far, a lot of people talk about surveillance, which is supported, but at the end of the day, I think we have enough information to know that AMR is a problem. Now it's time to move to action before we have to quantify it all the time. And I think focusing on mentorship, peer-to-peer mentorship, creating networks of pharmacists and nurses and physicians that talk about stewardship and behavioral change. I think that's really missing in a big part of the world. And also sharing tools. There are really interesting tools already available by different WHO agencies, but also different hospitals in different parts of the world. But taking that tool and contextualizing it and then sharing it. So let's say if I'm in a hospital in Lebanon, I found that this tool works for my context. Let me share this with my network and empower other stewardship people to work on it. And the last thing I'll mention, in addition to networking and mentorship, dedicating funding specifically for stewardship training. So we need to have champions in antimicrobial stewardship that are able to problem solve. And this doesn't apply only to physicians, it has to include pharmacists and nurses, so that they can also do some implementation research and look at, okay, what works for me in this hospital? How do I problem solve?
And since you are a medical professional, do you think there needs to be more stress on diagnostic stewardship also, because that is the first step towards getting the right medicine at the right time?
Yeah, absolutely. And in addition to diagnostic stewardship, you know, not only because at the end of the day, stewardship is using your resources in the best way possible. So diagnostic stewardship looks at, okay, do I really need to take this blood culture? And if I take this blood culture, how quickly am I going to respond to the results? And how quickly am I going to change my approach? In addition to that, but also empowering diagnostics. You know, very often it's much cheaper to buy an antibiotic and dispense it rather than buying the diagnostic. And that's a problem with the whole system. We need to find ways to make diagnostics accessible to everybody, so that we stop thinking of this empiric therapy approach where we try to find more rapid diagnostics available at the bedside, and in the clinic, in the pharmacy. Even, you know, when people focus too much on we need to restrict over-the-counter use of antibiotics. Yes, correct. But first, you need to make available universal healthcare where people actually access clinics, and then we can talk about. It's not that then, but in addition to that, then we can empower pharmacists to reduce their inappropriate prescribing and dispensing of antibiotics.
Okay. And lastly, your message, it may sound cliched, but I think you are an important person to, what is your message and expectation from the UNHLM, which is happening?
Thank you. I think it would be very successful if, for us as patient advocates, and is first to acknowledge, I mean, I think there's a bit of acknowledgement, but I think we need a lot more. We need a lot more funding, because a lot of work has been top down at this point in terms of, you know, stewardship and prevention, but I think we need a lot more bottom up work, and in order to do that, there needs to be acknowledgement that patients and civil society organizations have a huge role to play in empowering patients and empowering healthcare workers as well. So I really hope, if there was one thing that we can talk about, is empowering patients, because we hold all the stories, and if our stories are amplified to other patients, then we can find faster, simpler solutions that are in our hands, and you know, and I really hope that could work. In addition to, of course, thinking always about conflict and the impact on refugees and internally displaced people, and thinking also about how we can embed stewardship also into humanitarian support, because that's not enough just to give antibiotics to people who need it, it also needs to be done in a wise way.
Thank you very much. We were in conversation with Nour Shamas, who is a member of the WHO task force of AMR survivors, and we got a very good view from both sides of the fence, because she has been a carer for an AMR survivor and a medical professional as well. So from the point of view of a medical personnel, and from the point of view of somebody who has been affected by AMR, if not directly but indirectly. Thank you very much.
Thank you so much.